Good evening, ladies and gentlemen. Ronan can hear me, and that's the main thing. My name's Keith Gaynor. I'm a clinical psychologist, and I work in St. John of God's. And in many ways, I'm a bit of a quirky choice to do this lecture, in that I work primarily with depression. My old job, the job I used to do last year, was with borderline personality disorder, and it's not anymore. And in many ways, that story is a little bit also the story of borderline treatment in Ireland. And we're going to touch on that throughout the whole lecture and what it means. So what are we talking about when we talk about borderline? And when you begin to look at the name alone, it starts getting confusing. So some people would say borderline. Other people would say BPD. Other people would say EUPD. Other people would say developmental trauma. Other people would say long-term complex developmental trauma. People would say emotional dysregulation. People would say affect dysregulation. People would say go on and on and on. It's very easy to hear a clinician have a conversation. Are we going to have CBT or DBT for this person with BPD or EUPD? Of course, that just brings total sense and makes everyone very relaxed. So when you're looking at the research in this area, there isn't 5 terms, there isn't 15 terms, there isn't 25 terms. There is, in fact, 40 terms to cover this general area, which leaves everyone feeling a little like this. 1 million words all over the place, thrown at you, and it's very hard to discern what they mean. And you meet one doctor and he'll say one thing, you meet someone else who'll say something else, and you meet someone else who'll say something else again. And so when we're even trying to understand what are we talking about, we get a little lost. And I hope if we can do anything this evening is to bring a little bit of clarity, not total clarity, but a little bit of clarity to this area. So when we're thinking of people, just to say, I'm going to refer, for clarity's sake, to BPD through the whole lecture. I'm just going to use that one term, and I'm going to use that one term for 2 reasons. It's the term people are most likely to hear from a doctor in Ireland still. So if you go to your GP, if you go to your consultant, if you receive a diagnosis, that is the diagnosis you are most likely to hear. I also use it because that's what Margaret Linehan uses. And we're going to talk a lot about Marcia. She is the leading DBT expert in the world. And that's the term she uses. So we could use a lot of terms, but I'm going to use that one. When we're talking about BPD, it's very important to understand who we're talking about. Because everyone knows someone with depression, but probably nobody knows anybody with BPD. Even though it's quite common, it exists widely in Ireland and affects a lot of people. So somewhere where you can see BPD is, at the moment, in the Gate Theatre. And it's this character here. And that's Blanche Dubois in Streetcar Named Desire. And at the moment, in the Gate, there's a fantastic performance of this character. It's reasonable, it's a fictional character, but it's reasonable to say that if Blanche walked into a psychiatrist's clinic, she would come out with a diagnosis of BPD. There's something very interesting about Blanche, in that she's based on a real person. And the person she's based on is Tennessee Williams, a gay white man in the southern states of America in the 1930s. And that he based his own self on his experiences and created this character. But obviously he couldn't make it a male character for the time, so he made it a female character. Who else might we be talking about? Marilyn Monroe, one of the most famous women of all time, one of the most beautiful women of all time. When we look back through our history, would have met a lot of the criteria that we'd now understand as BPD. If we're looking for more modern aspects, I didn't know who this was, but somebody told me. This is Lady Gaga, apparently. I'm reliably informed. And again, it's very hard to say about someone you've never met and you don't know and you only see the media and a media manipulation. But again, a lot of her behaviour and a lot of her presentation would meet those kind of criteria. And this lady, who's a tiny bit less glamorous than maybe some of the others, but is maybe more important, because this is Margaret Linehan. And Margaret Linehan is probably the leading expert in BPD in the world today. She developed Dialectical Behavioural Therapy, that we're going to speak a little bit about, DBT, the only other three-letter acronym I'm going to use. And she works in the States and has worked in the States for about 30 years on BPD. And about 2 years ago, Marcia came out and informed the world that she herself had borderline personality disorder. And so she has all the randomized control trials, she has all the evidence, she has all the efficacy-based studies, but the first person she tested everything on was herself. And did it work for her? So a lot of the tone of this lecture, a lot of the point of this lecture is to try and differentiate BPD from depression. Obviously, everyone knows what depression is. We all know someone with depression. We've experienced periods of depression, perhaps. And yet BPD is this thing that's sort of silent, that sort of isn't talked about, that only happens over there to other people that we don't really know. And so when we're thinking about what BPD is, we're thinking a pervasive disorder of emotional regulation. So something long-term that affects how we regulate our emotional system. So for people with BPD, it encompasses all emotions, not just one or two. It feels overwhelming, and it's associated with a wide variety of behaviours. And generally, when we're looking at depression, we're seeing something that stops and starts, it's relapsing and remitting. People have long periods of depression, and then have long periods of wellness, and then long periods of depression again. It's generally associated with low mood as the primary emotion that's associated with. And it's associated with a reduction in behaviour. People do less. They struggle to get out of bed. They struggle to engage in their everyday activities. So when I say regulated emotion, what do I mean? And what I mean is what we feel every day. We have good mornings and bad afternoons. We have stressful Fridays and good Monday mornings. Or in fact, we probably reverse that. We have good Fridays and stressful Monday mornings. We have ups and downs, and we experience that all the time. We have a very stressful afternoon, we have a cup of coffee and a bar of chocolate, and we get through it, and we get into the traffic, and we go home, and we get on to do another day. And so normal mood and normal emotion isn't a flat line. It's a series of ups and downs, and that's how we get along. And if we're thinking here that our very best day, the very best day we've ever had, we're probably at a 10, and the very worst day we've ever had is probably at a 0, most of the time we're moving along between 6 and 4. It's never too bad. It's sometimes good, but it never becomes too awful for us. When we think about depression, it's moving there between 6 and 4, and then it crashes out. And it's low and low and low and low, and it stays low for weeks and months at a time. And people with depression will tell you how hard it is to shift out of that, to make that first step, to move out at that point. And then at some point, if treatment works and things go well, they do come out of it, and they go back to 6 to 4 to 6 to 4, and so on. When we think of bipolar depression, it's a whole period of weeks and months of a high, where everything is fantastic. I'm the best I've ever felt. Everything is going to go right. It's absolutely wonderful. And then the weeks and months of the crash, where everything is awful and I can't move again. When we think of emotional dysregulation, it's a little bit different. If we're thinking that a regular emotion is going between 6 and 4, a lot of people with BPD will say their regular emotion is moving between 7 and 3. While the rest of the world is a little bit German, they're a little bit Spanish. And that's just their normal thing. They're just a bit bigger, a bit louder, a bit more creative maybe, giving a bit more, holding back a bit less. And that's their everyday. And then somewhere, moving along there, a crisis happens. And it can be a big thing or a small thing, but it knocks them off kilter. And their mood starts moving much more exaggeratedly. So it's much wider and much more frequent. They'll experience those mood changes. So we're not talking about being depressed for a month. We're talking about a crash of depression at 9 o'clock in the morning, an elation at 10, and a crash of depression again at 11. We're talking a huge, rapid, frequent change in emotion that often doesn't have to have a huge trigger. There doesn't have to be a car crash or a grief or a loss of work for this to happen. It just hits. And the person has a sudden overwhelm of emotion. And like any of us can imagine, that's incredibly hard to deal with. That you're sitting there, you're in the office, somebody says something to you, and suddenly your emotions are ping-ponging up and down and up and down and up and down. So when we think of the type of emotions that might be ping-ponging, they're a little bit different for different people. For some people at those peaks, it may be all about anger. They get huge overwhelms of anger. For other people, it may be anxiety. For other people, it may be kind of being hyper or being hypomanic, where it's just excitement and fun and buzz. And people will then tell you about what it's like at the other end, the sadness or the hopelessness or the guilt or the shame or all the low mood that comes very quickly after that. And so there's one a good afternoon of feeling great. By evening, it's turned and it's dropped and it's awful. It comes around again and it goes down again. And it just builds and builds and builds until there's too many emotions. And rather than feel too many, often the person will numb out. And they'll move from a place of numb to a place of too much, to a place of numb, to a place of too much. And they can find it very hard to get themselves back in sync again to where they were moving along fairly happily. When we think of the behaviour that goes with this, because often BPD, the conversation with BPD starts with behaviour. And I specifically didn't do that, because everyone sees what the person with BPD does. They see the self-harm, or they see the addictive behaviour, or they see the huge fights, or they see the acting out, or they see the bigness. But they don't see the emotion underneath. And that's why it's very important and why we started with the emotion. But the behaviour that goes with those emotions is often interpersonal. So there'll be an interpersonal clash. There'll be a huge row. If you're feeling anger and anxiety and rage, who's going to get it? The person who's closest to you. The person who's standing in the room to you. The person who goes, would you like some tea? Or will you pick up that plate? Or, who's there. They're going to catch it. And suddenly then there's a row. You're always doing this. You never settle down. You're the one. And it becomes this bigger and bigger interpersonal conflict. There's the impulsivity that people would recognize with BPD. So doing things on the spur of the moment, things that people don't mean. And often that can become sex, drugs, and rock and roll, or other self-harm behaviours, or other addictive behaviours, other risky behaviours, or just a very long, impulsive streak. Self-harm, all the things that go with depression, the lack of activity, the difficulty getting up, the difficulty going to work, the difficulty acting, the difficulty doing is on the flip side of that. And so when somebody numbs out, where's the motivation to get up and go to college? When someone crashes to a low, where's the will to go and get back in and do another 9 to 5 and work? That's extraordinarily hard. And when we think of the cognitions, when we think of the thoughts that go with this, often they're along the line of, I can't cope, I can't manage this is too much. Because it is too much. It's just a perfectly good description. It is too much to experience. And then the things that go with that, the self-blame and the criticism. This is my fault. I'm doing this wrong. I should do this better. The self-hate and the self-hurt that go with that. So, although we often see the behaviours, and doctors and hospitals and parents and family see the behaviours, our understanding is about the underlying emotion. That's where we need to aim, and that's what we need to work on to change the behaviours. And we see the behaviours as a natural consequence of intense emotion. So, I'm shouting at you because I'm angry. It's not because I don't like you, and it's not because I don't like me, it's because I have this overwhelming feeling of anger. Or it's an attempt by the individual to regulate their emotion. And people often regulate, like the rest of the community, through not the most helpful ways. So most of Ireland regulates its emotion by pints on a Friday. They have a stressful week, they go for drinks. And so we see in BPD, we see addictive behaviours, we see self-harming behaviours, we see other addictive engagements, and they're there to try and control and reduce that emotion, that emotional overwhelm. And the thing is, those things work. 8 pints on a Friday works for that Friday. But it doesn't work on Saturday morning, and it doesn't work on Sunday morning, and it gets worse and worse and worse. And soon the addiction is the overwhelming problem. Equally, self-harm works for that moment. For that 5 minutes, it releases the tension. But it doesn't work 10 minutes later. It doesn't work 30 minutes later, and it doesn't work as a lifetime, as it becomes an addictive behaviour. frequent sexual engagement, having risky partners, having partners that you don't really like, being around people you don't really like, but keeping them there anyway. All of those behaviours are there to try and manage that sense of low mood or manage that overwhelm. So there's a good question as to why have we not been talking about BPD more? Why isn't this something that everyone is aware of? Because if you talk to somebody on the list, you're not, if you talk to somebody on the street, you're not going to know what BPD is. You go, well, I have BPD. They're not going to tell you. They know that and they understand that. They've met somebody with it. And that's because that has varying emotions. So some people will be more depressed. Some people will be more anxious. Some people will be more hypomanic. Different people will have different behaviours. So one person may self-harm, another person may have an addiction, or another person may just struggle in relationships or completing college. So you can have two people with BPD who sit beside each other who don't have any two things in common, except for their overwhelming emotion. And one of the key things that affects professionals is that people have different presentations at different times. So you'll see somebody on a Friday and they'll be one way, and you'll see them on a Monday and they'll present in a completely different way. And so that becomes very hard to diagnose and to treat and all the other things that will go with it. So one of the questions we might ask is, why does it develop at all? Where does it come from? Why is it there? And this is the DBT understanding of it. Firstly, that some people, we all have emotional variation. Some of us are German, some of us are Spanish. You'll know people who don't smile on their wedding day, have half a glass of cocoa and go to bed at 10:30. And you'll know other people who are up till 4 a.m, they're the last in the hotel bar and they have to be kicked out of the room. And that's just normal. We all know, when we look around our street, that emotional variation is there. And so we know that some people have bigger expressions of emotion. And that's just there. And some kids, when they're this big, are noisier kids. There's colicky kids. There's kids who cry more. There's kids who are more placid. And that's just there. Well, when you combine that with traumatic experiences, difficult emotional experiences, and especially traumatic experiences in childhood, that can often lead to emotional dysregulation. There's no one path, no more than there's any one person with BPD, there's only one presentation of BPD. But in general, you'll find that there's someone who had long-term emotional sensitivity combined with a traumatic experience. And when that happened, emotions started to dysregulate and they became very difficult to manage. And all the other things that we know about BPD started to happen. So people have an inability to think clearly or flexibly. We see the impulsivity and deliberate self-harm. People start developing an unstable sense of self. Since they can be a different person on a Friday than they are on a Saturday, how does anyone have a core sense of self? Who am I? Am I this person? Am I that person? And it's very hard for the person themselves to know who they are. And it leads, of course, to tempestuous relationships. Because if you don't know who you are, how does your partner know? How does your boyfriend? How does your girlfriend? How does your boss? How do your parents? And it leads to huge tempestuous relationships. Because someone will see you on a Monday, and it's great and fantastic and wonderful, and they'll come back Monday evening, and it's not. And of course, that's going to lead to ruptures. So, what are the effective treatments? There are 3 fairly well evidence-based treatments. They are all difficult to find. The one we're going to talk most about today and has the greatest level of evidence is DBT, which was developed by Margaret Linehan and first published in 1993. It combines weekly group skills, where people learn skills to manage their emotions, with weekly individual work, where people look at bringing those skills into their specific situations. So how do I bring that into college? How do I bring that into my marriage? How do I bring that into what I want to do? And plus 24/7 phone contact availability, so that when the crisis is happening, you're able to contact somebody who's going to talk you through the crisis. The schema therapy, developed by Jeff Young in New York, and that's primarily individual. And again, it also has 24-hour phone contact. and mentalisation, which was developed in London more recently, which is long-term inpatient, combined with individual therapy. Each of these has some common factors. The therapy lasts between 1, 2, and 3 years. Not one of them is shorter than 1 year. They're all structured. So if the person's difficulty is that their emotions are everywhere, you're going to need a therapy that works in the opposite direction. And so they're structured, and that there's a system to fit into. The person can buy into, and they know what it's going to be. At the core of each of them is a reliable, consistent therapeutic relationship that lasts over a long period of time. If you want to see the evidence and go through it, and I think it's well worth people do, if you go to nice.org.uk and look up BPD, there's a very good summary of all the available evidence up until I think that review was last year. So what's their evidence for? And have a look. One of the things to say from a therapy point of view, from being a therapist, is DBT is done by a team. It's not done by an individual. Mentalisation is done by an entire ward. It's not done by an individual. And schema therapy, even though you're seeing an individual, actually that individual is in their own support group. And there's a reason for that. That as a therapist, if the person that you're seeing, their emotions are moving X and Y and Z, and you're seeing them in crisis after crisis after crisis, the therapist burnout is really common. And so unless you are working in a team with a team around you, you won't last as a BPD therapist. And so when services are being set up, you set up a team and not one person. So we're going to talk a little bit about DBT because it is the therapy that's most common, that's most accessible in Ireland at the moment. And there's 2 key bits to it. And that's group, which happens once a week for about a year. And these are where you learn skills. And it's simply a psychoeducation group. It's not a psychotherapy group. It's a group where you learn skills. And they're in 4 different sets. So mindfulness skills, interpersonal skills, distress tolerance. So how do I manage my distress when it becomes overwhelming? And long-term, how do I manage my mood? Emotional regulation skills. And then individual therapy to help the individual manage their emotions day to day and to when and where to use those skills appropriately. And it's about understanding their particular triggers. We're going to talk a little bit about the D in DBT. And then working on actual responses in the moment. So not about general things, but how do I bring that to the workplace on Monday? How do I bring that to my marriage? How do I bring that to the relationship with my parents? And that also goes on. In general, DBT will be 2 years long, of twice weekly. 1 group, 1 individual. And so when we're thinking about what sort of treatment do we want, where do we want to see this? When the crisis happens and the emotional dysregulation starts, we want to put skills in there, 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 and there. And that's not saying that people won't feel emotion, but we don't want it to reach the peaks that it has been reaching, and we don't want it to change as frequently as it has been changing. Best of all, we want the skills to happen before. And that's about understanding the triggers. What sets me off? And it doesn't have to be something huge. It isn't the loss of a job or a car crash. It can be simply a word or a phrase or a memory or a thought. And it's about understanding what they are for me and recognizing them and dealing with them in advance. So one of the triggers that we know that happens a lot for people with borderline is they get caught in dialectics. This is the D in DBT. And a dialectic is an extreme where I get caught between one side and another, and it has no middle ground. So I may get caught, on the one hand, I hate being with this person. They're abusive, they're not nice, I don't like being with them, they make me feel worse about myself. It's a nightmare. But on the other hand, I can't be alone. So I can't leave. And the person gets caught between these 2 things. The intolerance of being able to be alone and the intolerability of being in this situation. And what will happen is being caught in between those two things will make the person dysregulated. It'll set their emotion off. It's a trigger. It's not something that seems to be solvable, and therefore my only response is emotional. Equally, people may have, very common dialectic will be between my own self-hatred. I hate myself so much, but I also don't want to hurt anybody else. So I get trapped between not liking myself at all and also trying to protect the people around me because I do love them, and not seeing any solution between those two things. The sense of when my emotions do become overwhelming, getting caught between that huge wave, that overwhelm, and being numb. And everyone hates being numb. It's not a pleasant place to be. No one enjoys. I met with a gentleman, but I met him yesterday. I said, I don't feel anything. And it wasn't that he's not depressed. He doesn't feel anything. And that's about him numbing out in order not to feel too much. And he can't find any point between not feeling anything and being utterly overwhelmed. He just doesn't have that middle ground. And a lot of the individual therapy done in DBT is about finding that middle ground. It's about finding the person, helping the person to find their dialectical dilemmas, the ones that are specific to them, finding where they crop up, when they crop up, and then looking at solutions, practical solutions to get out. So if it's about ending a relationship, it's about how do you end this relationship. If it's about making a relationship more tolerable, it's about how do you do that. If it's about changing job, moving job, if it's about managing emotion, it's about doing that and finding practical ways to get out of impossible situations. So, where is there DBT in Ireland? Not very much. There's a few spots, and as far as I'm aware, though I don't really know, there's about 200 HSE training places on the way. But again, when and where and how that's going to be distributed and how people are going to access them and how the people are going to manage waiting lists and all the rest, I don't know. The long and the short of it is that there isn't very much. So what I wanted to call this lecture was Eat the Damn Orange. But more people turned up than I expected. So some people have oranges and some people don't have oranges. And some people ate their oranges because it's a very BPD crowd. I bought as many oranges as Tesco had.
They're very nice.
You were meant to hold on to them. A key part of DBT. The first person to bring mindfulness into psychology. Obviously, mindfulness is a 3,000-year-old Buddhist technique. The first person to bring it into psychology was Margaret Linehan. And mindfulness is an absolutely key part of DBT. And getting good at mindfulness is an absolutely key part of DBT. Because it is one of the ways to manage emotion. And it is one of the ways to manage that overwhelm. So there's been a huge interest in mindfulness. And it can be summed up what it is in one sentence. To pay attention non-judgmentally in the moment. That's all it is, and it will only take you the rest of your life to learn how to do that. And I've been doing it 10 years, and I love it, but I'm not particularly good at it. Nobody is. It's something that isn't particularly easy. But all we have to do is pay attention in the moment and not bring judgment to it. So if something is negative, it's negative. If something is positive, it's positive. And we just experience that and let it pass. So this is exactly it. The man is there and he's overwhelmed and all his thoughts and all his stuff and everything. And the dog is there and he's just seeing the park. And one of them is mentally healthy and the other one isn't.
Let's be a dog.
Let's be a dog. And this is about, okay, if I'm walking in the park, I'm walking in the park. It may be a cold day. It mightn't be a perfect day. I might have forgotten my jacket. I may have got caught out in the rain. Maybe all the things that happen in Ireland on an autumn's day. But let's be in the park. And that for those 10 minutes, that's all I'm going to experience. And actually, if you can manage 10 minutes of just experiencing what's happening. That's extraordinary. That's really, really good. What I'm hoping, or we'll try and do it, it's not easy with a big crowd, is to eat an orange. So, how many oranges have we got? Can anyone who still has an orange lift it up in the air? Okay. So, how many people would like to share their orange with somebody who doesn't have an orange? What I'd like to do is 2 minutes of mindfulness with the orange, or with a segment of orange. You only need a segment. So, obviously eating is tricky for some people, and some people don't like sharing, and touching things is difficult. So, don't worry about it. I know. We should have done this at the beginning. So, what I'm going to do, I'm going to hang on to some of the orange. If you want to take a piece of orange and pass it on. So do at least some people have orange? Uh-huh. Okay, so what I'd like you to do is take one segment of orange. And just have this. Don't put it in your mouth yet. I'd like you just to begin to notice the orange. Notice the feel of the orange. Notice the smell of orange in the room. Now that we've opened 50 oranges, the room is actually full of orange. I'd like you to put it to your ear, and I'd like you to notice the sound of orange. I'd like you to notice the texture of orange. I'd like you to look at it and see the difference between the orangey bits and the pithy bits and the veins in it and the white bits and how white the bit in the middle is. And now I'd like you to take a small bite, just the top, and feel orange on your teeth. Feel the spray of orange. Feel, is it bitter or is it sweet? Is it pleasant or is it unpleasant? Feel the flesh as the juice flows out of it. Feel it being less and less and less. And then feel the orange as it goes down your throat and it ends. I'm going to try it one more time. We're going to take another bite. And feel what this bit of orange tastes like. I'm going to taste different. Is there anything about it? What do you notice? Does it sting a little cut in your mouth? Do you feel it on the back of your teeth? Can you hear the noise of the room eating oranges? It's extraordinarily noisy. And the sensation of just eating. Okay. And we should almost be down to the last bit of orange. I'd like you to take the last bit of segment and just slowly chew through the orange. Okay. And what we did there for about 2 minutes was 2 minutes of mindfully eating an orange. All we paid attention to was the orange. It had no function other than eating an orange. It had no purpose other than just to taste and smell and experience orange. And while we were doing it, our mind was engaged with orange. It wasn't somewhere else. It wasn't about traffic and cars and homework and work and bus stops and trams and all the rest. It was about orange. And mindfulness is simply about engaging with the things around us. Engaging actually with the world that's here, and not the world that's up in our head, and not the world that we're feeling in our chest. Just experiencing what it is, and experiencing it non-judgmentally. And it's one of the key skills in DBT. And DBT spends about 4 months on it, and we spent about 4 minutes on it. But in that 4 minutes, I hope you got a sense of what it's like just to pay attention. We could have eaten a whole bag of oranges in those 4 minutes. We often, in our lunchtime, we'll eat something and it's gone. We don't even notice its taste. You'll have a cup of tea while you're still running out the door to do the thing. And this is actually about slowing the whole process down and just experiencing every now and again the thing that we're experiencing. So I'm going to finish up because I know people probably have a lot of questions. And so it's a little recap on what we understand BPD to be. And that it's a problem of emotional dysregulation. The key bit to understand isn't the behaviour, isn't personality, isn't about the person. It's about what happens when emotion becomes dysregulated. And what a person does when they're trying to manage that. And sometimes they do things that work, and oftentimes they do things that don't work for them. And that's the bit we see. That one of the best ways to understand this is that there's a mismatch between the emotion the person has and the skills the person has to deal with them. Now, you would need to be a wizard to have been born with the skills you would need to manage BPD. But the whole point of a therapy like DBT is to give the person those extra skills, so that they have emotion that's this big and skills that are this big, and it's about getting the skills to match that. Most importantly, it's not just about what you do, because when you look at DBT, there's nothing magical in any of the skills. They're not extraordinary. They're very common sense, practical skills. But it's about putting them in at the right time. That after a crisis, after everything's gone wrong, after the blue lights have come, is a difficult time to put it all back together again. And if you can get in ahead of that, if you can get in the day before, the minute before the crisis hits, then that's much better. And so it's about long-term planning, it's about understanding triggers, and it's about putting in those skills early. When we look at what treatments work, generally it's about slow treatments, it's about consistent treatments, about treatments with a strong therapeutic relationship. So, for instance, I do a lot of CBT, and I do a lot of CBT for depression. And so an effective treatment of CBT for depression might be anything between 12 and 20 sessions. So you might see somebody for 3-4 months. That is going to be ineffective, and in fact it's going to be unhelpful for BPD. You see somebody nice like me, and then it's cut off 3 months later. You get a bit of what you need, just enough time to open up, and then it's taken away, and you're moved on, you go to somewhere else or something else. And so often people's experiences of services is chop and change and different, and we did something here and something there and a bit of something else. And it's not that any one of those things was wrong, it just wasn't long enough, good enough, and consistent enough over time. People with BPD will often talk about experiencing things for decades. I felt like this since I was this tall. I felt like this for the last 20 years. The thought that a treatment can do something in 20 weeks that's been going for 20 years just simply isn't practical. There is, without a doubt, a significant shortage of evidence-based treatments in Ireland. As far as I'm aware, there are some plans to address it, but we've yet to see how that's going to play out and what that is. And that one of the extraordinary things that's happened in Ireland over 10 years is that people have started talking about mental health in a way they never did. And that process is only starting, but it is starting. And I really believe that if there was anything worth campaigning for, I know it was World Suicide Prevention Day yesterday, and we talk about suicide in Ireland a lot, but we don't talk about BPD at all. And that if there was anything worth campaigning for, it would be proper services for BPD and an actual understanding of what BPD is. And this is one of these things where actually the people with the power on over there, that you guys have much more power than therapists do to provide the services that are necessary. Because you have access to TDs, you have access to your local community, you have access to people in the HSE, that the people of Ireland, if they want it, can make it happen. And you see, when they want something to happen, it happens. On the other side, we work in a service that tries to provide what it can, when it can, within diminishing funds. And so I think if there's anything that people would like to campaign for, I think this would be a very worthy thing. And that's me.